Hyperprolactinemia. Prolactin chemistry. It is alcohol soluble polypeptide hormone. A source anterior pituitary lactotropes, acidophils, lactotrophic hormone. Function on the mammary gland to stimulate lactation. A normal level 0.2 to 29 nanogram per milli. Control prolactin inhibiting factors, which is dopamine from hypothalamus. Form. There are four forms of prolactin hormone according to molecular weight: small, big, big, glycosylated. 80% of prolactin are present in the small form. Prolactin is increased by estrogen, serotonin, and thyrotropin releasing hormone. Galacturia. A definition: any persistent discharge from the breast except blood or pus in the absence of lactation. It is more commonly bilateral. Diagnosed by microscopic examination, fat droplet, and Sudan 3 stain. Hyperprolactinemia in male, galacturia, and impotence. Physiological causes. Normal pregnancy, there is increase in prolactin due to high estrogen. Lactation, there is reflex suppression of prolactin inhibiting factors. Stress, even if minor, as vaginal examination or collection of blood samples. Sexual intercourse, sleep, hypoglycemia. Other causes: primary hypothyroidism due to increased thyrotropin releasing hormone 2 to 5%. Polycystic ovarian syndrome, mild elevation due to raised estrogen level. Chronic renal failure, decreased excretion of prolactin. Chronic liver failure, decreased metabolism of prolactin. Ectopic source of prolactin secretion, such as lung and renal tumors. Iatrogenic antidopaminergic drugs, estrogen and combined oral contraceptive. Antidepressant tranquilizer, such as diazepam. Antiepileptic, metoclopramide. Antihypertensive, reserpine and methyl dopa. Clinical pictures: anovulation, amenorrhea, oligomenorrhea, irregular bleeding. Prolactin inhibit the pulsatile gonadotropin releasing hormone, making ovary refractory to the action of pituitary gonadotropin. Luteal phase defect, as prolactin enhances luteolysis. Infertility and recurrent pregnancy loss. Galacturia. Squeeze each quadrant of the breast from the periphery toward the nipple, as some lobes might not be affected. Hyperprolactinemia is a cause of anovulation in about 20% of patients with ovarian dysfunction. Galacturia is only present in 30 to 60% of hyperprolactinemia. Galacturia may present with normal prolactin level, indicating hypersensitivity of the breast tissue to premenstrual syndrome. Hirsutism, Prolactin increase adrenal androgen and decrease synthesis of sex hormone binding globulin. Manifestation of pituitary tumors such as persistent headache, visual field defect. Investigation, history and examination. First, exclude pregnancy, lactation, drugs, thyroid function test, prolactin level. Say if 0.2 to 29 nanogram per milli, it is a normal level. If more than 30 nanogram per milli, it is polycystic ovarian syndrome. So do ultrasound plus LH على ال FSH ratio. If more than 100 to 200 nanogram per milli, it is highly suspicious of pituitary adenoma. Indication to assess prolactin level: galacturia, primary and secondary amenorrhea, anovulation, luteal phase defect, and repeat early abortion, infertility, and unexplained infertility. For etiology, you have to do CT scan or MRI, it is better, plus visual field examination. CT scan detect macroadenoma. MRI detect macroadenoma plus 70% of micro. Treatment: hyperprolactinemia secondary to specific causes such as hypothyroidism, drugs induced, appropriate management is given. Idiopathic hyperprolactinemia, dopamine agonist. Bromocriptine, barlodil. It is an ergot alkaloid 2.5 mg twice daily, given with meals or vaginally to avoid nausea, given at night to avoid postural hypotension. Cabergoline, Dostinex, 0.5 mg tablet, less side effect but expensive. Long-acting, half tablet given twice weekly. Lizorid, Dubergine, 0.2 mg tablet, more potent but less nausea and vomiting. Quinagolid, Norbrolac, gradually increasing preparation. If got pregnant, adenoma may enlarge. Effect of estrogen, continued dopamine agonist, not teratogenic. Follow up with visual field each trimester.